for our great magnus, mourning eyes, the true visits, with deep grief, by breaking belief, we stand as one united, by hiding in plain sight. See the real glory, Ilvamani we are, by breaking all the walls, indestructible than ever, Ilvamani we are. Stiga, strong magus, Yai is the savior of Ilvamani.
Ilvamani presenting the case for the Grand CPC. The patient is brought in with a chief complaint of weakness and dyspnea. Now, this mimics the ongoing COVID-19 pandemic, maybe? Could it be a viral pneumonia? Let's find our way out of this mysterious presentation.
Salient features regarding our final diagnosis are weakness, shortness of breath, on and off chills and fever, fatigue, myalgia, known history of hypertension, remote history of deep vein thrombosis, splenectomy, pancreatitis due to cholelithiasis, also, osteoarthritis for which the patient had undergone knee replacement, positive result of anti-nuclear antibody test, tachycardia, and slight chest retraction during physical examination.
And now we need to proceed to sorting out some key differential diagnoses for our case. This could be quite challenging.
Differential diagnosis. The first differential diagnosis is community-acquired pneumonia. We considered this diagnosis because of the patient's age, lack of precautionary measures, fever, chills, shortness of breath, weakness, myalgia, and we ruled out this diagnosis as there were no crackles or rales during physical examination, no tachypnea, there was decreased tactile fremitus, also there was no cough, chest pain, or purulent sputum noted. Pulmonary embolism. We considered this diagnosis because of shortness of breath, weakness, patient's remote history of deep vein thrombosis, splenectomy, and history of knee replacement surgery, as well as fever and tachycardia. We had to rule out this diagnosis as the X-ray findings of pulmonary embolism were not seen in our patient. Ischemic heart disease. We considered this diagnosis because the patient had a history of known hypertension, also the patient's age and shortness of breath. And we ruled out this diagnosis as there was no chest pain or any acute presentation of symptoms. Viral pneumonia, probably COVID-19. We considered this diagnosis because of fever, chills, myalgia, patient's age, history of remote splenectomy, history of hypertension, lack of precautionary measures, chest X-ray findings of bilateral consolidation, and it cannot be ruled out.
Acute respiratory failure.
We considered this diagnosis because of the patient's age, history of hypertension, weakness, dyspnea, history of splenectomy, and it cannot be ruled out.
It's time we reach out to our Thunderbird. He always knows best when it comes to the final diagnosis.
Our final diagnosis is acute respiratory failure secondary to COVID-19. Let's talk about pathological findings. The most common histological findings in ARDS is diffuse alveolar damage, ischemia pneumocytes. There is damage to alveolar capillary endothelium and type 2 pneumocytes leading to alveolar septal edema and the formation of the hyaline membranes.
Coronary artery disease (CAD) is pre-existing condition. It is caused with plaque buildup in wall of the arteries that supply blood to the heart. This causes the lumen of the arteries to narrow over time. This process is called atherosclerosis. The risk factor to develop coronary artery disease in our patient are splenectomy, age of 77, hypertensive and sedentary lifestyle.
Yes. There is also fibrin deposition within and around the capillaries, which explains the thrombotic pulmonary angiopathy. So, firstly, I will tell you briefly about COVID-19. So, this acronym was derived from coronavirus disease 2019, is defined as illness caused by novel coronavirus, now called severe acute respiratory syndrome coronavirus 2, formerly called 2019 novel coronavirus, which was first identified amid an outbreak of respiratory illnesses cases in Wuhan city, Hubei province in China. Let's discuss about our case. Our patient is a 77-year-old male who presented with weakness and shortness of breath. He had history of fever and chills with no cough. These are very non-specific symptoms and don't point to disease entity in particular. The case also specifies that the patient did not follow proper protective measures and could have been exposed to many sources of infections. With current scenario in the world, SARS-CoV-2 infections is highly likely given in the risk factors present in this patient. The patient was splenectomized in the remote history. Risk factors in this patient: age of 77, hypertensive patient, and history of splenectomy. Let's talk about X-ray interpretation. The X-ray shows consolidation and diffuse bilateral ground glass opacities. This as a result of exudative process because of inflammatory process in the lung tissue. Even though tissue findings can be seen in many other lung pathologies, the presentation and the time of presentation all correlate with the findings of COVID-19. According to a study done in China on radiographic findings, these findings were consistent with COVID-19 diagnosis. According to the post-mortem X-rays, bronchograms of patients diagnosed with COVID-19 were noted in addition to the before mentioned findings.
Let's understand the pathophysiology of our main diagnosis. The pathophysiology of our case is as follows. The patient fails to use protective measures. As a result, the virus enters the alveolar cells via inhalation and binds to the angiotensin-converting enzyme 2 receptors present on them. The coronavirus envelope fuses with the cell membrane and the RNA is injected into the cell. This RNA in turn gives rise to more viruses, replication occurs, and then finally those viruses are ejected from the cell, causing damage to the host DNA. There is thus a binding to the pattern recognition receptors. This inflammatory response further causes the release of damage-associated molecular patterns and cytokines like interleukin beta, interleukin 6, tumor necrosis factor, granulocyte colony stimulating factor, and interferon gamma. These cytokines cause symptoms of fever, chills, myalgia, and weakness as in our patient. This leads to endothelial activation due to direct damage of the epithelium-endothelium barrier, increasing the permeability of the lung capillaries. This leads to exudation of plasma into the alveolar spaces and interstitium, which results in interstitial alveolar edema. The edema produced impairs the gas exchange between the alveoli and capillaries, leading to a severe compromise in the exchange of gas, producing a hypoxic state. Hence, the oxygen supply to the tissues is decreased. The myocardium fails to cope up with the increasing demands due to reduced supply of oxygen. A contributory factor to this is the patient's atherosclerotic process, which is leading to hypertension in this patient. Atherosclerosis is the hardening of the arteries due to the buildup of cholesterol plaques in the walls of the arteries, causing an obstruction of blood flow due to the nature of a narrowed lumen. The very same vessels fail to dilate in response to a decreased oxygen supply. This in turn results in the decreased contraction capacity of the myocardium, causing the patient to eventually succumb to a cardiac arrest, thereby causing the death of the patient. And let's examine the cause of death.
The immediate cause of death in our patient is thus due to acute respiratory failure. The diffuse alveolar damage with coronary artery disease being the antecedent cause of death, and the underlying cause of death is due to COVID-19 infection, mostly due to coronary arterial atherosclerosis.
thank you all for visiting our world of the fantastic beasts.
Okay, Dr. Palmero, you can start asking questions now.
Okay, good evening, students.
Good evening.
Good evening.
Evening, Doc.
Okay, anybody can answer the question. Okay, my first question is discuss how pneumonia is developed in COVID-19. So start from the mode of infection until the patient died.
Yes, doctor. So I'd like to answer this question.
Okay, go ahead.
And the history given in our patient said, yes, doctor. So the history given in our patient was clearly mentioned that the patient did not use any protective measures. And it was a very recent case. In fact, the date mentioned for the knee replacement surgery was 2019. So keeping a high suspicion of COVID-19, that's how we proceeded with our case. So we think that the patient did not use any protective measures, and hence he would have inhaled the COVID-19 virus through air droplets. And we know that the major organ that is affected in COVID-19 is the lungs because of the presence of the ACE2 receptors that are present here in the alveolar and epithelial cells. So as a result, the virus has bound to these receptors that are present and has actually increased the inflammation in the area. Also, we know that the patient has a history of hypertension. So, and the age is 77. So atherosclerosis would have worsened this condition in our patient. And as a result, the virus would have again affected the other organs and also the blood vessels. So this would have led to a prothrombotic state in the patient. And all of this cascade of events would have further worsened the condition and led to a sudden respiratory failure, leading to the cause of death in our patient, doctor.
So how the pneumonia develops, how the virus evolved into pneumonia.
Okay, doctor. So this is again at the surface of the alveolar epithelial cells. We know that we have the alveoli on one side, and on the other side we have the blood vessels. So at this level, the ACE2 receptors that are present are basically affected by the host, by the virus. So it injects the RNA and multiplies here and replicates further and further, damaging the interstitium that is present in this level of the alveoli and the blood vessels. So this would have again hastened the process.
So you mentioned the endothelium, right?
Yes, doctor.
Yeah, okay. So now, okay, because if the patient will have pneumonia, or in this case, based on the X-ray, the patient manifested with hypoxia,
yes,
dyspnea, and cyanosis. Okay, those are the symptoms. But how can you tell me pathophysiology why the patient has a hypoxia, a dyspnea, and cyanosis? And somebody can answer.
Yes, doctor.
Not Lakshmi. Okay.
Doctor.
Elizabeth.
Yes. Good evening, doctor. So the thing is, the virus enters the cells, as Lakshmi said, through ACE2 receptors. And once it enters the cell, it induces an inflammatory response through the dams, and as a result, interleukins and cytokines are released, which is pro-inflammatory. So as a result, the blood vessels become more permeable to plasma leakage. As a result, there is exudation of plasma into the interstitium and into the alveoli. Now, alveoli are sites where gas is exchanged into the blood. So when there is fluid or when there is anything that increases the thickness of the alveoli, there is impaired gas exchange, which causes decreased oxygen in the blood. So this is why the patient presents with cyanosis. Also, because the respiratory centers are detecting lower oxygen in the blood, the patient has a response as in shortness of breath. Thereby, the patient, there is hyperventilation, there is tachypnea. So that is what is causing these symptoms in this patient.
What type of interleukin is involved?
Interleukin 6.
What type of
interleukin 6, interleukin 1, these are causing the fever in the patient. There is a tumor necrosis factor and gamma interferon as well.
Okay, can you tell me more about the role of interferon?
There are cases in which interferon actually is pro-inflammatory. So when there is a inflammatory response above normal, it adds to the the disease process as well. So also there are reports where there is said that patients with deficiency with interferon cannot produce a inflammatory response to the COVID-19. Therefore, that is the basis where interferon treatment is initiated in patients so as to as part of treatment.
Okay. My next question is for Bawani. Okay. Can you hear me, Mr. Bawani Singh?
Yes, doc.
Okay. Can you your differential diagnosis is one of your differential is what's this? ARF, okay, acute respiratory failure. So, what do you think is the primary cause of acute respiratory failure? I read your differential diagnosis on your paper. Is it correct? One of your differential is acute respiratory failure. So why did you consider acute respiratory failure?
Doc?
Oh, yes. Go ahead.
I can answer it, right, Doc? Yeah. Okay.
3 minutes left.
Yeah, okay, Doc. So actually, the reason that we consider acute respiratory failure is because initially we had considered a list of diseases, and along with actually that was part of the final diagnosis. The final diagnosis COVID-19, secondary to the AR of acute respiratory failure. The reason why we put it in the differential diagnosis is because we wanted to rule out our main diagnosis compared to the other 3 differential diagnoses. So that's the prime reason that we had put ARF in the differential diagnosis part. So to differentiate from the rest of the other differential diagnoses that had a close correlation with our patient's symptoms. And regarding the reason for the acute respiratory failure in our patient is because so the main reason for the acute respiratory failure in our patients is because as my friends were saying right now regarding the virus invading the lung, and it had caused lung pathology which had developed pneumonia. So there had been an impaired gas exchange in our patient. So that impaired gas exchange had led to a dyspnea in our patient, and also the patient had a pre-existing atherosclerosis. So that atherosclerosis, what happened that atherosclerosis led to a reduced coronary blood flow to the heart, which impaired the myocardium of the heart to reduce its contractility. So this plus this together contributed an exacerbation of the patient's symptoms, and that led to an acute respiratory.
Okay, stop. One more, because we have only 1 minute left. Okay. Another question. What do you think? Because on your cause of death, you said that the underlying cause is COVID-19 infection, and another one is coronary artery arteriosclerosis or coronary artery disease. So, based on your underlying, which caused the death? Coronary artery disease or COVID-19?
It was the COVID-19, doc. Actually, the coronary artery disease had been for a longer period of time. I could give you the risk factors, like the patient was hypertensive, the patient was elderly, the patient had a splenectomy that was done. Also, the patient was living in America, so there is a higher chance that he might have a sedentary lifestyle. So it had been there for a longer period of time. When the time the patient encountered the COVID, what happened was the COVID exacerbated all of his symptoms with regard to the CAD that we had been telling, as in the atherosclerosis. So, greater part of the manifestation was because of COVID, and yeah,
I think time's up.
That led to the death of the patient.
Okay, Doc. Time's up, Doc. Thank you very much for joining us, Dr. Palmero. Yeah. We'd like to acknowledge Dr. Ritualo, who's also listening into the call. He's here in the call. Okay, so
Good evening.
Good evening, doctor.
Good evening, doc.
Okay, so thank you, Team Ilvermorny. That ends your Q&A portion. You may now leave the chat. I will stop recording now.
Give us spirit, give us fire, give us strength and take us higher. We the champions, we are back here, we are better, we have no fear. Pick up your feet, Armstrong is here, get ready to cheer and chill now. Yeah. Armstrong is stronger, Armstrong is better, ready to fight it, ready to hit our flag. Armstrong is better, ready to fight it, ready to hit our flag. And never flag, and never flag, and never flag. Oh, oh.
We don't know what happened to the Dumbledore. It's a mysterious death. Don't worry, brother. Armstrong is here to help you. But first, I need to use the things. Yeah. Now, let us look at the salient features of this case. He was a 77-year-old man from Oklahoma, USA, who came in with the chief complaint of weakness and shortness of breath, had fever and on and off chills, and was exposed to numerous sources of infection, had difficulty breathing, myalgia, and hypertension. He also had diabetes, splenectomy, and pancreatitis. He has a past medical history of osteoarthritis, for which he underwent a knee replacement surgery. He was tested positive for ANA and has a rash over his knee. No known history of familial diseases. He came into the clinic incoherent and conscious and went into cardiac arrest. His blood pressure was 0-0, heart rate was 0-0, with slight chest retraction and no neck vein engorgement. He was previously tachycardic. Codes in the ward and its analysis. The patient went into cardiac arrest during transport to the hospital and then died shortly after arriving. CPR and intubation were given, but still the patient died. Postmortem examination was also done. Postmortem AP chest radiographic findings indicated that the patient had white lungs, that is, more than 75% of bilateral lung parenchymal involvement was seen, and also greater than 75% of bilateral lung considerations were also seen. Multiple air bronchospasms, crazy paving sign, honeycomb sign, and irregular opacities were also seen bilaterally in the patient.
Let us now look at some of the differentials of our case. Our first differential is myocardial infarction. We ruled in this differential because our patient is 77-year-old male with a chief complaint of weakness and shortness of breath. He is a known case of hypertension and had cardiac arrest on the way to hospital where CPR was given. Also, the history of remote deep vein thrombosis and tachycardia supports our diagnosis. But he has no chest pain, nausea or any heartburn, no family history of cardiac disease or neck vein engorgement, nor any edema or cyanosis noted. Also, there are no reports related to serum biomarkers or any proof of ECG, so we ruled out this differential. Our next differential is pulmonary embolism. The reason for ruling in this differential is that, being a 77-year-old man with weakness and dyspnea, he underwent surgery last October for bilateral knee replacement, which also resulted in positive ANA test. Added to this, he also had a history of remote deep vein thrombosis. He is a known hypertensive patient, which reveals a cardiac abnormality that supports our differential. The absence of D-dimer test, related lab tests, and lack of edema and cyanosis, and on the X-ray, the absence of Westermarck sign and Hampton's hump clearly rules out this differential. Our next differential is congestive heart failure. We ruled in basically because our patient is a known case of hypertension. Being a resident of United States, where the leading cause of death is heart disease, he comes with the chief complaint of weakness and shortness of breath, fever and on-and-off chills. He had cardiac arrest on the way to hospital and CPR given by the emergency team, which raised our suspicion. X-ray finding shows cardiomegaly, widened mediastinum and hilar lymphadenopathy, which supported our diagnosis. But he has no cough, no chest pain, no family history of heart disease, no neck vein engorgement and no peripheral edema noted. Also, absence of evidences of ECG or echo helps us to rule out this differential. Our next differential is community-acquired bacterial pneumonia. We ruled in this differential basically because he is an elderly patient with weakness, dyspnea, on-and-off chills and fever. History reveals that he has been exposed to a potential source of infection. He underwent splenectomy, which made him immunocompromised. His BP is palpatory and slight chest retractions are observed. The given X-ray clearly shows bilateral consolidation and ground glass opacities, which supports this differential. But he has no cough and chest pain, no wheezing and tachypnea, nor any recent travel history or any recent hospitalization, nor any sputum or microscopic results available. So we ruled out this differential.
Let's move on to the final diagnosis. But before few highlights from the case. Being elderly male patient from USA, which is currently ranked number 1 with highest number of COVID-19 cases, presenting with signs and symptoms since a week, that is acute onset, along with respiratory failure which is not related to heart failure or fluid overload, along with bilateral opacities on the chest X-ray, we conclude to our final diagnosis of acute respiratory distress syndrome secondary to COVID-19. Let's move on to the pathogenesis of COVID-19. This elderly male patient was exposed to numerous potential sources of infection along with all added comorbid condition, was on high suspicion of having COVID-19 because this virus will enter the body via various routes, but primarily it is transmitted by respiratory droplets and contact routes between the people, after which it gets attached to the nasal and bronchial epithelium, but mainly to the type 2 alveolar cells with the help of spike proteins by means of ACE2 receptors primarily. Once attached, this gets endocytosed into the type 2 pneumocytes and start making its RNA copies, finally releasing several other viral copies into the bloodstream by damaging epithelial-endothelial barrier. This activity accentuates inflammatory response and triggers influx of several other inflammatory cells, releasing huge amount of cytokine or say cytokine storm, which will give rise to pneumonia. This pneumonia will progress to severe pneumonia, giving rise to hyalinization of type 2 alveolar cells and causing diffuse alveolar damage with histopathological changes of infraalveolar edema, hyaline deposition in alveolar walls and hyperplasia of type 2 pneumocytes. Now this uncorrected pneumonia will accentuate shortness of breath along with myalgia, weakness and fever due to accelerated inflammatory response, finally consolidating bilateral lung parenchyma. Eventually, this uncorrected severe pneumonia along with dysfunctional alveolar capillary oxygen transmission will lead to acute respiratory distress syndrome, due to which patient succumbs to death. Let's look on to the cause of death. Our immediate cause of death is acute respiratory distress syndrome secondary to COVID-19. Antecedent cause is severe pneumonia. Underlying cause is suspect of COVID-19 with contributing factors of hypertensive male, splenectomized and positive anti-nuclear antibody profile.
Algorithm of COVID-19 classification. A patient who is the resident of Oklahoma City, USA have influenza-like symptoms. With the help of clinical presentation, we suspect him to be a patient of COVID-19 under severe category because our patient is older than 60 years. Further testing should be done to confirm COVID-19. On the basis of disease severity, WHO classified COVID-19 into mild disease, moderate disease, severe disease, critical disease. And as we have already discussed, our patient falls in critical category as he has acute respiratory distress syndrome. Now, before moving on to the management of COVID-19 patient, as per the recommendation of WHO, we need to have a look on care for healthcare professionals, which include all the precautionary measurements like wearing PPE, mask, shield, safety goggles and shoe cover. So let's move on to the management of critical COVID-19 with ARDS as per the recommendation of WHO. In adult patient with severe ARDS, prone ventilation for 12 to 16 hours per day is recommended. In patients with moderate and severe ARDS, a trial of higher positive expiratory pressure instead of low PEEP is suggested. In patients with moderate severe ARDS, neuromuscular blockade with continuous infusion should not be routinely used. Vitamin D, a hormone precursor produced by the body with the help of sunlight. As we all know, vitamin D insufficiency affects the immune function as it exerts an immunomodulation role by increasing innate immunity. Like calcitriol, which is the active form of vitamin D, acts as an immune system modulator. It also enhances innate immunity by increasing the production of antimicrobial peptides such as...
Now?
Kung nandiyan na sila.
Nandiyan na po silang lahat, ma'am. So,
Okay.
you may start asking questions po.
Good morning.
Good morning, doctor.
Morning,
I have read your, I have seen your presentation. Well, the Harry Potter theme was quite was quite exciting. But I have a question regarding your presentation because outright your diagnosis an autopsy. Was there an autopsy report or a clinical presentation? Just a clinical what?
Yes, doctor. Clinical presentation, doctor.
Kasi it's a clinical pathologic report, no? I have observed in your presentation there were no laboratory findings, right? I only saw clinical symptoms, and then the history of present illness was very short. It was only I think the clinical presentation, the history of present illness is only from the ambulance, right? So your diagnosis was based more on the symptoms and not really the findings, right? You had a clinical history of. I had a difficult time absorbing where you got the COVID, no, because it was an outright diagnosis of a COVID, no, and but there was a cause of death. I saw a cause of death there. So it was purely based on symptoms and not really on an autopsy finding, right?
Yes, doctor.
Because if I am to look at your case, no, I would really go for a bacterial pneumonia. I would go for a bacterial pneumonia, considering that you had a history of on and off fever for how many days, right?
6 days.
Yeah, 6 days of on and off fever, and with associated findings of difficulty of breathing, no? And then your x-ray showed there a white lung. You said a white lung, but that was already during the time of death. That was a post-mortem x-ray, tama? Right?
Yes.
Okay, so if you were to look at this patient, for example, this patient has been in your ER what other things would you request? Just to confirm, without, don't think that this is pandemic, okay? Assume that today is a regular day and then you had this patient in your ER. What could you have requested?
Okay, doctor. Myself, Jyoti Jha. I would like to take up this question. So this patient, when it comes to ER with complaints of fever, chills on and off from 6 days, myalgia, weakness, and shortness of breath, along with slight chest retraction, which was given in the case, I would have requested immediately for a chest X-ray, ECG. I would have done arterial blood gas. Along with that, some laboratory testing, like I would have sent for complete blood profile, renal function test, liver profile test, and coagulation profile test to look for the pathology. I would have done a bedside ECG to check to rule out if it is any cardiac emergency. And along with that, I would have monitored the patient with, I would have checked all the vitals. I would have noted down all the vitals of the patient, like the pulse, BP, temperature, heart rate, those findings, doctor.
What would you expect for the ABGs if you are confronted with that particular patient? What is your expectation of your ABGs?
Okay, doctor. So since we don't know the patient's past history, I expect if the patient is diabetic, he would be acidotic, maybe he is under ketoacidosis, or if the patient is having respiratory illness, in that case also I would have been seeing respiratory acidosis in the given ABG. With,
okay, so assuming that this patient is ketoacidotic, how would you compensate for this patient?
Okay, doctor. Assuming that patient is ketoacidotic, that means patient is hyperosmolar with high glucose values in the blood. So immediately I would have blood sugar.
Okay. Okay.
So high blood sugar. So immediately I would have given some stat insulin, regular insulin dosage, 10 units. Along with that, I would have hydrated the patient. And with hydration, I would have put him on chart. I would have put the glucose chart to monitor the blood glucose, and based on the values, I would have corrected his the glucose levels.
You are correcting the glucose levels, but not the gas.
Yes, for acidosis. So in diabetic, it is always metabolic acidosis, what we see in the ABG. To correct that, I would have given soda bicarb immediately to correct the acidotic stage, and I would have hydrated the patient.
Okay. So now, if for example, we're not talking of COVID, We're not talking of COVID here. Okay. So for example, your patient is he had difficulty breathing with history of fever, and what particular test would you order in order for you to confirm whether there is a bacterial pneumonia? Because I saw in your cause of death pneumonia, right?
Yes, doctor.
What happened that?
So, doctor,
in your X-ray, the white lung would suggest that there is really concern. Hello. Yes. Okay. So what could have confirmed your bacterial pneumonia?
Doctor, along with chest X-ray, we would have looked into the complete blood picture. So in bacterial pneumonia, we expect high leukocytosis. And along with that, we would have checked for serum LDH, serum ferritin, and hemoglobin levels to see what is the status. And in bacterial pneumonia, usually there will be pleural effusion. So we would have tried to check the cytology of the pleural fluid to check if it is bacterial pneumonia or not.
But this is only 6 days old, so your pleural effusion might not be in there yet. So the best thing for you to do is to do a what? just to determine what particular organism is growing in your
Culture.
Okay, so what are you going to do? Okay,
Um,
so you do a blood culture, okay, and sensitivity. Okay, so I saw there also that one of your differentials is your congestive heart failure. What was your basis for that?
Congestive heart failure, the main sign and symptom of congestive heart failure is shortness of breath. So our patient had shortness of breath, difficulty of breathing. So along with that, patient is known hypertensive, chronic hypertensive. So that made us thought of congestive heart failure.
Okay, but you ruled it out because what was your reason for ruling it out? Hello? Nawala na. Nawala na.
Jody, are you there? Are you there?
Hello,
Jody?
doctor.
Hello,
Hello, doctor. I am Sukanya. So, hello, doctor.
Yes.
Yes.
So, doctor, there was internet lag. Doctor, why did we rule out congestive heart failure? The reason was there were no signs and symptoms of heart failure like neck vein engorgement, raised JVP, peripheral edema, or hepatomegaly, ascites. Such symptoms were not present in the patient. So, along with that, we didn't have diagnostic supportive data like ECG or echo reports. So, we ruled it out that this is not heart failure.
Okay, so aside from the fact that there is already cardiomegaly and things, no, but one thing that you could improve on this particular what you could have improved in this particular case is you should have completed the laboratory findings. Was it given to you? That case was given to what?
We were not given with lab reports and diagnostics other than chest X-ray.
Okay, but what you could have suggested, no, right? You could have suggested the different laboratory findings for you to really find out, because it's difficult to put a cause of death as such, secondary to COVID, since this is pandemic, when you have all the signs and symptoms presented to you pointing to a pneumonia. Okay, and pneumonia at that particular age, when the patient is really compromised, this is not duly secondary to COVID. There are other things that could have caused it. Okay, so congratulations to your group. I had a good time watching your video. Yeah, I just had a little something with your presentation because everything else was based on symptoms and not really because of the laboratory findings. Okay, so when you go out in your clinics, it's very important not only to consider the symptoms but also to base on your laboratory findings. Okay, again, congratulations.
Thank you, doctor.
Thank you, doctor.
Okay.
Thank you, doctor.
Okay.
Thank you, doctor.
Thank you, Dr.
Okay.
Espiritu, for joining us today.
Okay.
Okay. And thank you to Team Durmstrang for participating. It's a very good Q&A. Okay.
Thank you, doctor.
I will stop the recording now.
Good morning, judges, doctors, and everyone viewing us out there. I am Tavish Pandit, the leader of House Muggles. Without any ado, let's get started. Muggles, pack your stuff, get ready, move! Muggles, what you're trying to do? COVID-19 pandemic in the air. It's not going to spread. Stop, it's our time. Our time. Guess who's back again? Oh, you don't know? Oh, you don't know? I bet you know as soon as we walk in. Wearing yellow jeans, black jeans, intelligence to the roof. Don't look too hard, might hurt yourself. Know the path of the struggle very smooth. Oh yeah, we're marvelous camp with some witty answers. Keep up. So many questions around and still giving an answer. Yeah. Why you said fix your face, ain't a fault, we are rocking so up. Muggles, pack your stuff, get ready, move. Muggles, what you're trying to do? Tell me what you're trying to do. COVID-19 pandemic in the air. It's not going to spare. Everywhere we go, they be like, oh, the muggles. Everywhere we go, they be like, oh, the muggles. Everywhere we go, they be like, oh, the muggles. Nah. Watch us break it down like, coronavirus. It's a pandemic. What's the sound? Coronavirus. We need some magic. Come on now. Coronavirus. It's been so tragic. You're Salient daily, it's free of killing. Muggles, pack your stuff, get ready, move. With the best, let's go prove. The case for Grand CPC 2020 is a 77-year-old male from Oklahoma City, USA. He's married, who came up with a chief complaint of weakness and shortness of breath. The history of present illness, associated symptoms, and on and off chills and fevers, no cough. Patient went into cardiac arrest during transfer to the hospital and died shortly after arrival at the hospital. He was exposed to numerous infectious exposure since he was not taking precautionary measures during this pandemic. Now, the review of symptoms. So we have weakness and fever, difficulty of breathing but no cough, myalgia and weakness. If we'll go to the past medical history, so the patient has a history of hypertension, remote deep vein thrombosis, remote pancreatitis due to cholelithiasis, and if we'll go through the past surgical history, we will find out that he underwent splenectomy for an unspecified genetic disease. Osteoarthritis status, the patient went into a knee replacement surgery last year in October 2019, and with subsequent development of rash over the knees, and he had positive ANA. After the past medical history, let's go to the family history. So the patient has no known history. Moving on to the physical examinations after the patient came to the hospital. Since he went into cardiac arrest during the transfer to the hospital, the patient was incoherent and unconscious. So the physical signs found at that moment were heart rate 0, blood pressure 0, no visible scars on skin, anicteric sclera, no vein engorgement, and if we'll go through the chest and lungs, symmetric chest expansion with slight retraction was there, but no crackles. A dynamic precordium, tachycardic, and no murmur. And on the extremities, we could find no cyanosis. The cardinal signs were nil since the patient already went into cardiac arrest. Now we have the salient features. The salient features are weakness, difficulty of breathing, on and off chills and fever, no cough, exposure to numerous potential sources of infection, fever and weakness, myalgia, hypertension, remote deep vein thrombosis, remote pancreatitis due to cholelithiasis, no cyanosis, no edema. So these are some important and significant salient features. So the chest radiograph is given to us. So this chest radiograph is done at the time of post-mortem. So you can see there is no heart, but what we could find was consolidations and bronchograms. So the patient is having shortness of breath, weakness, and was having fever since a week. So I think the possible cause would be COVID-19 virus, and for that also he was not taking any precautionary measures like mask or anything as sanitizers. So I guess the initial impression would be COVID-19 infection complications.
Just because the pandemic is going on, you can't just roll out all other diseases. We have important things like ANA positivity, thromboembolic complications are also there. You have to consider pulmonary fibrosis as a complication of rheumatoid arthritis because there is an important thing of ANA positivity. Also, there was a rash over the knee. So you can know that it's a systemic disorder because the patient had fever and also chills. He also had weakness. Also on the X-ray you can see pulmonary fibrosis.
Wait a second, Dr. Rana. there was symmetrical lung expansion and there was no crackle heard in our patient. So that cannot be pulmonary fibrosis. I think it is community acquired pneumonia because our patient had difficulty in breathing, fever and chills, and also the X-ray shows consolidation, and our patient had myalgia and immunosuppression due to his splenectomy.
But to say it's a community acquired pneumonia, you have to have the common symptom of pneumonia, which is the cough. Also, the patient does not have cyanosis. Also, you cannot ignore pulmonary embolism. The patient had a history of remote DVT. So to rule it in, we have symptoms like chills and fever, pulmonary edema, which you can see consolidations on the chest X-ray. Also, the patient has shortness of breath, myalgia. In the risk factors, you can consider the history of the knee replacement surgery and also the history of DVT. Also, the patient had splenectomy way earlier. Also, the history of hypertension.
Dr. Rana, I think you forgot why you ruled out community acquired pneumonia. You said there was no cyanosis, okay? And in addition, there is no edema. It is not pulmonary embolism. As everything is getting ruled out, I think Dr. Tavish was right about COVID-19 infection.
Yes, Dr. Nikunj. That's why I said it's COVID-19 infection. If you want to see the rule-ins, just check them out. Shortness of breath, on and off fever, chills. In the X-ray, you can see consolidations, myalgia, and other risk factors for COVID-19 complication. There are age, hypertension, knee replacement surgery, remote DVT, and splenectomy because it causes immune suppression. And in today's time, if you'll talk about rule-outs of COVID-19, I'll just say one line as stated by Center of Disease Control and Prevention organization, and that is CDC is still updating more about COVID-19 symptoms list as they are learning more and more every coming day. That's how new COVID-19 is. That's why we don't have a criteria to put it in a rule-in and rule-out system.
So much Dr. Rahul and Dr. Nikunj for helping me out. You came up with such great possible differentials for this case. But now, no, it's not only COVID-19 infection complications. In fact, it is community-acquired SARS-CoV-2 pneumonia. And Dr. Rahul, now can you explain the pathophysiology behind it?
Coronavirus is a single-stranded enveloped RNA virus. Once the virus gets into the respiratory system, it loves to attack the alveoli and attaches to type 2 pneumocytes. These viruses have S-spike proteins. These proteins bind to the ACE receptors on these cells. Then the virus is engulfed into the cell. Once inside the cell, it replicates by the process of translation. In this process, the type 2 pneumocytes starts to become damaged, so they release specific inflammatory mediators. These inflammatory mediators stimulates macrophages, and then these macrophages starts to create specific cytokines like interleukin 1, 6 and TNF-alpha. These cytokines causes endothelial cells to undergo dilatation and increases the capillary permeability. This will cause all fluid and plasma to leak out into the interstitial spaces and alveoli. All this fluid accumulates in the alveoli and causes alveolar edema. The inflammatory mediators also releases a tons of neutrophils. While trying to destroy the virus, they will also destroy our own alveolar cells. All this cellular debris and leaked plasma will eventually lead to decreased gas exchange.
Now we have an alveoli containing cellular debris and exudate. Alveoli, now there is a decrease in gas exchange, which means there is a hypoperfusion and hypoxemic state. Now there is an increased work of breathing, which will lead to ARDS, acute respiratory distress syndrome.
I know some comorbid conditions that have exacerbated the COVID-19 infection and lead the patient to coronary artery disease during ARDS. Age. With aging, patients have reduced immune system efficiency and also vasoconstriction induced by vascular modulators and increased risk of agonist mediated vasodilation. In these old-aged patients, COVID-19 increases vascular resistance. Our patient had pre-existing hypertension and that made him more susceptible to the endothelial injury. Also, he had splenectomy, and with his aging, we can say that production of B cell and T cell in the bone marrow and the thymus is reduced. Patient was male. According to some studies, males are more susceptible to COVID-19 infection because ACE2 receptors are high in the males. COVID-19 increased endothelial dysfunction by generating a detrimental hypercoagulable state. Some researches show that the history of DVT and PE can lead to thromboembolic complications in patient, which is relatable with our patient. So these are the comorbidities I have researched on.
Wow, that was very much impressive, Dr. Rahul and Dr. Nikunj. Thank you for explaining so much about this disease and this case. That was really important for me as well as for our viewers. So now I'm pretty sure about the cause of death. The immediate cause of death would be ARDS, acute respiratory distress syndrome. The underlying cause of death would be COVID-19 pneumonia. And the antecedent cause would be, as Dr. Nikunj said, it would be coronary artery disease. That was our case from House Muggles. Thank you everyone for watching. And yes, I'm pretty sure we are the best and we proved it.
And Dr. Podriel, you may start asking questions.
Hello everyone.
Good morning, ma'am. Hello, good morning, ma'am.
So for your first question, you stated that your patient had cardiac arrest on the way to the hospital, isn't it? So can you explain the pathophysiology behind it? Why the patient had cardiac arrest, the pathophysiology behind it?
Patient have cardiac arrest because of the ARDS.
मेरा काम चल रहा है
Because of the ARDS, there is deposition of the carbon dioxide in the lungs, and this causes the excess deposition of the carbonic acid, and this carbonic acid causes the damage to the lungs and heart, and this is why this patient have the cardiac arrest.
Any more? Anyone wants to add any more?
Yes, doc. If we'll go to the pathophysio, if the case was of COVID-19 infection, if we'll talk about COVID-19 infection, so it has direct influence on the blood vessels as well. So it can lead to a hypercoagulable state in the blood vessels, which might lead to a kind of coronary artery disease or some other kind of heart manifestations. So when the patient is already having shortness of breath and the manifestation has already involved the lungs, so also for the repair or maybe the formation of new alveoli or type 2 cells, we need blood supply from the heart. And if that is compromised and already the alveoli are getting damaged, so there is more workload on the heart, as well on the same time there is more workload on the alveoli. So these things like ARDS and cardiac arrest might happen simultaneously, because if we'll talk about cardiac arrest, so our heart will ask for more supply from the heart, and if the heart is getting already stressed out because of hypercoagulability, so it may get under workload.
Okay, but your patient even had hypertension, isn't it?
Yes, doctor.
Oh, yes, ma'am.
Aged patient. So
Yes.
do you think that the pathophysiology could have been the hypertension leading to atherosclerosis and the patient had cardiac arrest? Is that possible for this patient, or is it clear-cut COVID case?
Yes, doc. For
Oh.
hypertension also, it's one of our comorbidities. I would like to ask my friend Dr. Nikunj, who has explained the hypertension part for the comorbidities. He might explain it well.
Yeah.
Yeah.
You are taking the hypertension as the comorbidity. Could hypertension leading to atherosclerosis and cardiac arrest could be the sole reason for the death, the main reason for the death in this patient?
Ma'am, it can be a sole reason, but we can say it is a comorbidity because hypertension in our patient, he is old aged. Secondly, he is male, and we show some research that says like males have high ACE receptors, and COVID virus affect directly on the ACE receptors, and then it damages the endothelium of the blood vessels. So it can lead to coronary artery disease or atherosclerosis, as we say, but it is a comorbidity. It can't directly lead to death.
Because the symptoms are being shown since a week only, and the symptoms are mainly for fever. So obviously there's a thing that has aggravated the heart conditions. So yes, we can think in many ways about the death of the patient, whether it's heart conditions, because hypertension is also a very main factor, but we are trying to stick to our diagnosis. so there's no more confusions.
Your patient died shortly on next question. Okay, your patient died shortly on arrival to the hospital, right? So
Yes.
what are the prognostic factors that determined for a severe COVID patient? What are the prognostic factors?
So, doctor, for COVID patient. Okay.
Oh fuck.
For a severe COVID patient, like your patient who could not even reach the hospital. So, what could be the prognostic prognostic factors to determine a severe COVID patient?
Yes, doc, since we haven't seen or we were not provided with any labs or any such kind of things earlier, so we can suppose like the prognostic factors would lead to like respiratory manifestations like diffuse alveolar damage, or which might lead to ARDS. So things like that, because we came to know like for a week he's having fever or he's showing symptoms of shortness of breath. So there was already manifestations of the alveoli and lung parenchyma. And
Not prognostic factors you would like to see to determine whether that patient is a severe COVID patient or not.
For me, the most important would be the CBP, complete blood picture. It will.
What are the findings? What do you see there?
Like the lymphocyte count. That is the most important for me. Like below 1,000, it's low, and
What
if
happens-
there is,
What happens to the lymphocyte count?
it decreases.
Why?
Because they are working very hard. Like because there is damage to the cells, then there is cytokine response.
Cytokine storm.
Cytokine storm, yeah.
Apart from lymphopenia, what other findings do you find?
Like the CRP also increases. Normally the CRP is from less than 1, but when
Okay, any more findings?
Yes, doc. There are a lot of questions, like a lot of tests we can do. Sorry, I couldn't understand at first. So there are D dimers for the heart. We have troponin levels, and then we have lactate dehydrogenase, CRP as he already mentioned, and
we have serum ferritin as well.
yeah, serum
Also,
ferritin.
ferritin is increased in this COVID-19 patient. Right?
Okay, now the next question. You mentioned about the ACE2 receptors. So apart from the lung, where do you find these ACE2 receptors with high expression? Which all organs?
Yeah, in the heart as well, there are a lot of ACE2 receptors, especially in males, as we already said. And other than that, in our respiratory tract, there are also like some are the hypothesis and we are not confirmed yet, but some people are showing like confirmed results. So in nasal area, there are more ACE2 receptors. That's why they are saying like nasal swabs are more good to take rather than oropharyngeal swab. Other than that, liver, kidneys, GI tract also, because that's why patients show like diarrhea like symptoms. So in GI tracts also there are a lot of ACE2 receptors.
So does COVID affect your GI tract? Have you seen any case, or do you know about anything that
In some cases, GI tract has been infected by COVID-19 as well, and it has been manifesting till I think mucosa, and it is creating complications for GI.
Yeah, like ma'am, sorry, because it's from the beginning of COVID, from the beginning of pandemic, there has been a symptom, like the diarrhea is the symptom. It's like around 10%. But
diarrhea is the symptom. So is the fecal-oral route also a mode of transmission for COVID-19?
yes, ma'am, there are studies which shows that fecal-oral route is also part of transmission. Like the persons who are living in the same building, there has been reports saying that because of the plumbing, the other people got infected.
Okay, so you mentioned that age is one of the comorbid condition for this patient.
Yes.
So why do children have less mild form of COVID than elderly people? Why? That the children
One of the thing is like the total peripheral resistance increases in the older patients, while it happens opposite in the younger patients. Like they have decreased total peripheral resistance.
Anyone wants to add any more points?
Yeah, ma'am, about the immunity we can talk, like if you would like to compare older patient with younger patients. So the immunities levels, like the weak immunity in older patients has been a very much big factor for in case of COVID-19. And also like older patients are prone to have diseases like chronic diseases like diabetes or hypertensions. Also some diseases like that can also manifest and worsen the disease prognosis.
Okay. So what histological findings could you find in this patient, in the lung of this patient? Post-mortem on autopsy?
From
the main thing is the diffused alveolar damage.
As in our case, yes, diffuse alveolar damage is one of the histological
Like from the X-ray we can
where
say
we can find highly membrane formation can be also there if there is diffuse alveolar damage, and exudates are present. I think accordingly with the lung, only these things we can attain from the specimen.
Anyone wants to add anything?
Yes, ma'am. Cell debris or like in COVID patients, there are like similar findings as others. Like there are some kind of like bronchiectasis found in some COVID patients. Also, there are exudates in CTs. In live, for example, in CTs, it has shown ground glass appearances.
No. I'm
Also,
talking about the histological findings, not the CT. The autopsy histological findings of the lungs.
I think the most specific would be the diffuse alveolar damage.
Okay, can you explain it?
Because when the neutrophils comes, they while attacking the virus, they also attacks our own cells, the alveolar cells. So there is damage to the type 2 pneumocytes previously from the virus itself, and then our own cells like neutrophils and interleukin-6 also attacks our own cells.
Okay, now what histological findings do you see under the microscope?
Death of these cells.
Features of DAD, can you explain in detail?
Like clinical symptoms, ma'am?
No, histological findings. What do you see under the microscope in DAD? This ARDS, whatever the case.
cell debris without nucleus.
Apart from that?
Neutrophil cells present there, like our interleukins present there, cytokines.
You cannot see the cytokines and the interleukin in the histological findings.
Yeah, but we can see the dead cells.
You describe the tissues. How do the tissues look? What is the morphology there?
Let me go to
That is the confirmation, isn't it? If you have not done a PCR test before the patient dies, so that is the confirmation, the autopsy findings, the histological findings.
Yes, ma'am.
Yes, ma'am. We will find a lot of like neutrophils and like dead cells, debris.
But also, ma'am, in
In the
autopsy,
alveolus
RT-PCR is followed, like for the specimens.
Okay, yeah, but I'm talking about the microscopic ones.
Microscopically, to DAD, we can find hyaline membrane formation in under the microscope or the
Okay, so the next question, why do you think your patient was unconscious?
Because of low oxygen saturation, ma'am.
So
it can lead to, if there is low oxygen perfusion in tissues, especially in brain. So things like confusion, then unconsciousness, things like this proceed.
Okay. So, can you explain to me about the management, the precautionary management you would like to give to any patient?
Like, ma'am,
prophylaxis, like prophylaxis treatment, man, or the
prophylaxis.
Okay, so prophylaxis treatment we give firstly the azithromycin, then doxycycline, the antibiotics, and then in some cases we give the if the patient have fever we can give paracetamol to or acetaminophen, and then if the patient is showing some symptoms we can give hydrochloroquine, and we have to confirm the CRP levels and other things for that. And then if the physician find that it is suspicious the CRP levels, then he can start the Fabiflu or Remdesivir. If the patient is very severe, then the physician can start the Remdesivir to him or her.
Okay, so our time is up. So hope you all enjoy the questions. Good luck further.
Thank you, ma'am.
Okay, thank you, Dr. Podial. Thank you, Team Muggles, for participating in this Q&A. I will be stopping the recording now.
That was so delightful and enjoyable presentations, and more so a very informative one. Now let's move on to the second part of the competition, which is the MCQ portion.
Okay, good day, everyone. Here is the first question for the Grand CPC. Doc Sarah, you may proceed.
Okay. Kindly settle in, all students, as we prepare for the first question. So here we go. These are the participants for the question number 1. We have Ayajan Jandu from the Muggles group, Sheikh Momina from the Albermorny, Gahen Rahan Manish from the Voldemort group, and Shan Mugam Deepak Surya Darmstrong. So all the participants kindly prepare for the question. Okay, for the question 1, it is considered as reservoir of SARS-CoV-2. A. Camel, B. Civet, C. Cats, D. Bats. Again, I repeat the question. It is considered as reservoir of SARS-CoV-2. A. Camel, B. Civet, C. Cats, D. Bats. Key in your answer right now. Okay, all answers are in now. 1, 2, 3. Okay. The answers are all in, sir.
Okay. Who got the answer? The answer is?
And the answer is letter D. Everybody got the right answers.
Score in.
Okay, Doc Billy, please share your screen.
Share the screen.
Okay,
Can you see it?
Here are your scores for question number 1. Okay, thank you everyone for joining. You may now leave the chat.
So you have for the participants, you have 15 seconds to settle in. For question number 2, in this case, what is the most likely cause of secondary hypertension? A. Coronary artery disease. B. Chronic renal failure. C.
systemic metabolic disorder, D, autoimmune disorder. Again, in this case, what is the most likely cause of secondary hypertension? A, coronary artery disease, B, chronic renal failure, C, systemic metabolic disorder, D, autoimmune markers. You have 15 seconds to answer. Okay, time is up. All answers. One more, okay? One more group.
Next. Give the correct answer first. All our questions. Oh, yeah.
And the correct, okay. And the correct answer is letter A.
So everyone got it correct, Doc.
Oh, this is the
Okay.
score.
Yeah. Yes.
Ma'am Janice, please verify.
Yes, sir. Okay na po.
Okay.
So, check audio, check video muna.
Okay,
Everybody.
audio and video, please turn it on.
Wala ata si Sundaresan.
Nandito si Sundaresan, Doc.
Wala pang video. Turn on the video. Video, Sundaresan, turn on your video.
Daresan, Kirtiga,
turn on your video.
please turn on your video. Okay, videos on.
Okay, good. Verify. Okay na?
Okay na po yung verification.
Doc, I have some internet lag.
You have internet lag? Okay. Let us know if you're not seeing the questions or the slides properly, and we'll try to adjust for you. Okay.
Okay, read instructions.
Okay, so to proceed with
I
question.
can't hear you.
Yes, come again. Okay, shall we continue?
Continue.
Okay, so to proceed to question number 3, the following participants are from Muggles. We have Francis Febin. From Armstrong, Chiti Babu Sadish A. From Ilvermorny, Sundaresan Kirutiga. And from Voldemort, we have Vashish Himanshu. Okay, participants, please get ready.
Doc, I can't see you. Doc, I can't see your.
Okay.
Hello, Doc, I can't see your slide.
Oh, you can see
Hello?
You can see the slide.
So from what group are you?
Ilvermorny.
Also, can you not see the screen?
Can you see the slide with the participants?
Sundaresan.
You can try turning off your video so that
See the slide, Doc.
No
same
question.
slide.
No question. There's still no question slide.
No question yet. No question yet.
Are you ready?
Ready, Doc? Switch na po kayo sa bubbles.
Okay.
Bubbles. Switch to bubbles. 15
Thanks
seconds.
for
15 seconds.
We're going to prepare for the questions now. After this will come the question slide.
Okay, for question number 3, what laboratory test would you request to, I cannot see that, to support your final diagnosis? Again, the question is, what laboratory test would you request to support your final diagnosis? A, cardiac enzymes. B, renal function test. C, autoimmune markers. D, nucleic acid analysis.
Timer.
Please key in your answers in the chat box and send it to Iftizar Haron.
Okay, time's up.
Time's up.
Bubbles. 15 seconds. Check answers, please.
Only one, okay. Two groups. Two groups send their answer.
Okay, we'll wait for the for another 2 groups. Okay, and the right answer is letter.
Wait.
Okay.
Are all answers in?
1, 2, 3. 3 groups. 3 groups. 3 groups only.
Okay. Give the answer.
Okay. And the
Once
answer
the answer is given, that's a red. Just finish.
What about the other group? Can we not wait? Shall I give the right answer now?
Yes.
If you give the right answer, that's it. That's a finish.
Okay, and the right answer for question number 3 is letter D, which is the nucleic acid analysis.
Okay.
Got the answer.
Okay, Voldemort, C. Alvermorny, B.
Wait. Baltimore.
C.
Alvermorny, B. And that
Tell me you got the right answer.
Okay, sorry. And the right answer is from 2 groups, Darmstrong and Muggles. Letter D.
2. Okay,
Darmstrong and Muggles.
Okay. I'm sharing now. Sharing screen now. Scores, please check.
Okay, so here are the scores after question number 3. Okay, everybody, all the students, thank you for participating. You may now leave the chat. So, hello everyone. Please turn on your videos. Okay, all of their videos are on. So this is question number 4. Ma'am Janice, please verify.
Sir, they are all verified.
Okay po. You may now proceed.
Okay. Okay, so for question number 4,
the participant.
Okay, the following participants are the following. From Muggles, we have Sesumani Kiloyopurani. From Durmstrang, we have Yetokuri Rohit. From Ilvermorny, we have Gahera Tanvi Kantilal.
Yes.
And from Voldemort, we have Thika Anurag. Okay.
Yes.
Participants, please get ready. The question is, in acute respiratory distress syndrome, the most common histopathologic findings are the following except A, diffuse alveolar damage, B, emboli, C, congestion of capillaries, D, hyaline membrane formation with fibrosis. Again, in acute respiratory distress syndrome, the most common histopathologic findings are the following except A, diffuse alveolar damage, B, emboli, C, congestion of capillaries, D, hyaline membrane formation with fibrosis. Time starts now. Time is up.
Time's up.
Time is up.
Bubbles, bubbles. You got the answer.
Not yet, sir.
Well, answers are all in.
Yes.
Okay, who got the correct answer? The answer is
And the answer is letter B, emboli.
Okay.
got the answers.
Only the Ivory who got the correct answer. Yes, only the Ivory. The rest got it wrong.
Okay. Okay, sharing now.
We will consider only the first answer. Okay.
Yes.
Sharing.
Okay, so these are the scores after question number 4. Thank you, students, for participating. You may now leave the chat. Okay, good day, everyone. So, Ma'am Janice, please verify.
Okay na, sir.
Okay,
Okay na?
you may now proceed.
Okay. Okay. So these are the following participants to answer question number 5. From Muggles, we have Yarlagada Yashwat. From Durpstrang, we have Amarjot Singh. From Ilvermorny, we have Vagela Priyarjish. From Voldemort, we have Baskaran Surya Lakshmi. Okay. Participants, please get ready.
Bubbles.
Bubbles.
15 seconds.
And the question is, type of specimen or swab sample with highest yield of positivity to detect the presence of the virus in this case. Letter A, BAL or your bronchoalveolar lavage. Letter B, NPS or your nasopharyngeal swab. Letter C, your OPS or oropharyngeal swab. And letter D is lung parenchyma. Again, the type of specimen or swab sample with highest yield of positivity to detect the presence of the virus in this case. Letter A, BAL or your bronchoalveolar lavage. B is the NPS or nasopharyngeal swab. C, OPS or oropharyngeal swab. D is lung parenchyma.
Timer.
Starts now.
Submit your answers now.
Please send your answers, key in the answer, and send it to Dr. Iftizar Haron.
Bubbles. Correct answer.
And the correct answer is letter D, lung parenchyma.
Okay.
Correct answer.
Okay, 3 groups got the correct answer. We are from Darmstrong, Muggles, and Alvermony.
Okay.
Doc Chan, where are you?
Okay, Doc will.
Sharing. Correct?
Okay, so here are the scores after question number 5, everyone. So all students, thank you for participating. You may now leave the chat. Okay, everyone, hello. Please turn on your videos. Okay, Ma'am Janice, please verify.
We're verified already.
Okay, you may
Everyone
now,
is in na po.
everyone's in. Okay, you may now proceed.
Okay, so we're now in question number 6. The following participants are from Muggles, we have Lamba Parag. From Durmstrang, we have Raju Darsana. From Ilvermorny, we have Gundala Yeshwat Kumar. From Voldemort, okay, from Voldemort, we have Malepudi Dimple Priyanka. Okay, participants, please get ready.
Timer.
Okay, so the question is SARS-CoV primarily spreads via one of the following routes. A, aerosol spread. B, droplet and direct contact. C, fecal to oral route. D, through contaminated surfaces. Again, SARS-CoV primarily spreads via one of the following routes. A, aerosol spread. B, droplet and direct contact. C, fecal to oral route. D, through contaminated surfaces.
Timer.
Time starts now. Okay.
Time's up.
Please key in your answers and send it to Dr. Iftisar Haron.
Answers is...
And the correct answer is letter B, droplets and direct contact.
Who got the answer?
Okay, everybody got the correct answer. It's letter D.
Sharing. Okay.
Okay, everyone. Here is the scoreboard after question number 6. Thank you very much for participating. You may now leave the chat. Okay, good day, everyone. Please turn on your videos. Okay, your videos are on. Ma'am Janice, please verify. Ma'am Janice.
Okay na po.
Okay, so you may proceed.
Dila, you are muted. You are muted. Muted pa rin. Still muted yan. Go ahead.
Okay po. Okay, everyone. So this is question number 7. Participants are the following. For Muggles, we have Burma Naman. For Durmstrang, we have Gaju Monica. For Ilvermorny, we have Paloju Sai Kumar. And from Voldemort, we have Shaba Jagadish Reddy. Okay, students, participants, please get ready. Okay, the question is, what is the most sensitive method for diagnosis of all stages of viral diseases? Letter A, viral culture. Letter B, indirect fluorescent antibody. Letter C, shank smear. Letter D, nucleic acid-based detection. Again, what is the most sensitive method for diagnosis of all stages of viral diseases? A, viral culture. B, indirect fluorescent antibody. C, shank smear. D, nucleic acid-based detection. Your time starts now.
Time's up.
Time's up.
Bubbles.
In your answers to the chat box and send it to Iftizar Haron.
Answers in. Correct
Yes.
answer.
And the correct answer is the letter D, nucleic acid-based detection.
Okay, everybody got it.
Very good.
Okay. Sharing. Scores now.
Here are the scores after question number 7. Thank you everyone for participating. You may now leave the chat.
Thank you.
Hello.
So, good day everyone. Please turn on your videos. Okay, I think all of your videos are on.
Okay, so we're now in question number 8. Participants are the following. For Muggles, we have Bolipali Sweta. From Durmstrang, we have Kapara Sai Tejashwini. From Ilvermorny, we have Monsi Ajay. From Voldemort, we have Polapoti Balagurunatan Dipa. Okay.
Bubbles.
Participants, please get ready.
Bubbles now.
Okay, so the question is, the entire cycle of coronavirus's replication occurs in one of the following. A, cytoplasm. B, reticuloendothelial system. C, mitochondria. D, nucleus. Again, the entire cycle of coronavirus's replication occurs in one of the following. A, cytoplasm. B, reticuloendothelial system. C, mitochondria. And D, nucleus.
Timer.
Time starts now. Okay, time's up.
Bubbles.
Please key in your answers to the chat box and send it to Dr. Iftisar Haron.
Answers in. Correct answer is.
Are all answers in? And the correct answer is letter A, cytoplasm.
Okay, only the Darmstrong got the correct answer.
Okay, scores there.
Okay, so here are the scores after question number 8. Thank you everybody for participating. You may now leave the chat.
Okay.
Okay, wait. Hello, good day everyone. Please turn on your videos. Okay.
No.
Everyone's is here. Harsh, please turn on your video.
Turn on the videos, please.
Nalaya, please turn on your video, if possible. Okay, Harsh is on.
Nalaya.
Nalaya. Nalaya, please turn on your video. Nantini? Nantini? Okay. Okay. Ma'am Janice, everyone is verified?
Harsh, turn on your video.
Yes, Doc. They are already verified.
Okay.
Wait.
Network issue. Okay. So please proceed.
Okay na po?
Yeah, okay.
Okay, guys, so we're now down to the last two questions. And this is question number 9. Participants are the following. From Muggles, we have Nalaya Nathini. From Durmstrang, we have Manas Samduram Bharat Reddy. From Ilvermorny, we have Potaychami Praveen Kumar. From Voldemort, we have Sojitra Harsh Kiritba. Okay. Good luck, students. Please get ready. Okay, and the question is, what is the most likely cause of positive ANA in this patient? A. ARDS. B. Metabolic systemic disorder. C. Chronic renal failure. D. Osteoarthritis. Again, what is the most likely cause of positive ANA in this patient? A. ARDS. B. Metabolic systemic disorder. C. Chronic renal failure. D. Osteoarthritis. Time's up. Oops. Sarah, we have all the answers?
Yes.
Okay.
And nobody got
And the correct answer is A. ARDS.
No correct answer.
Yes, that's the right answer. No one got the right answer.
Okay, sharing. Score.
Okay, here are the scores for question number 9. Thank you everyone for participating. You will now leave the chat. Okay, good day everyone. Please turn on your videos so that Ma'am Janice can see.
We're verified.
All of them are verified? Okay. You may now proceed, ma'am.
Okay. Hello, students. So this is the last question. Participants are the following. From Muggles, we have Rajkumari Sebatini. From Durmstrang, we have Varanasi Chandana. From Ilvermorny, we have Rajendra Nesamani Paul Frederick. And from Voldemort, we have Kartikeyan Kirtana Priya from Voldemort. Okay, so this is the final question. From among the comorbidities of the patient, what contributed to the immediate cause of death? Letter A, pancreatitis. Letter B, genetic disease. Letter C, cholecystitis. And letter D, hypertension. Again, from among the comorbidities of the patient, what contributed to the immediate cause of death? Letter A, pancreatitis. Letter B, genetic disease. Letter C, cholecystitis, and letter D is hypertension. Your time starts now.
All answers in.
Okay. All answers are in.
The answer is.
And the correct answer is.
Now let us all welcome Dr. Serviliano Ritualo, Chairman of the Department of Pathology, JFSM UPHR, for the presentation and discussion of the case. This is to be followed by the closing remarks message from the Dean of the JFSM UPHR, Dr. Emelita Gatmaitan.
Good morning. Let me welcome you to this discussion portion for the Grand CPC of the November Customized Batch. I am Dr. Serviliano Ritualo III, Professor, Chair and Coordinator of the Faculty of Pathology, Junelto Foundation School of Medicine, University of Perpetual Health, Delta, here in Las Piñas, Philippines. But before I continue, I would like to express my gratitude to the President, President Anthony Tamayo, our Dean, Dr. Emelita Gatmaitan, and the Coordinator for the Customized, Dr. Cha Ramos. I would also like to congratulate in advance the different members of the different houses that presented this morning. And finally, I would like to thank the judges for their participation and cooperation. Dr. Joseph Palmero, Dr. Paul John Ablasa, Dr. Bernadette Espiritu, and Dr. Prigia Pujal. Disclosure. The use of this CPC case was approved by the Oxford University Press, American Journal of Clinical Pathology, to be used for educational purposes in the subject Clinical Pathological Conference and Special Topics in Pathology, CPC-STP, under license number 4911240056-199, dated September 17, 2020, for copyright clearance. Also with written notary from Dr. Sanjay Mukhenpai, the Director of Pulmonary Pathology at Cleveland Clinic, and Associate Editor, Pulmonary American Journal of Clinical Pathology, for the use and mention of this case. Methods. A complete postmortem examination were performed according to the standards procedures in a negative pressure autopsy suite isolation room using personal protective equipment including N95, mask, eye protection, and gowns. The diagnosis of coronary disease 2019 or COVID-19 was confirmed by real-time reverse transcriptase polymerase chain reaction testing on postmortem swabs. Methods. Testing for COVID-19 was performed on nasopharyngeal swabs taken during external examination of the body. Lung tissue swabs were taken immediately after opening the body and collected in a sterile manner from an incision of the lung parenchyma. The swabs were immediately placed in transport media and sent to the State of Oklahoma Department of Health Laboratory, where real-time reverse transcriptase polymerase chain reaction testing was performed. General data. The deceased was a 5 feet 7 inch, 200-pound individual with a body mass of 31.8 kilograms per square meter. Evidence of emergency medical intervention was noted during post-mortem examination, including intubation and chest compression, abrasions, and bilateral anterolateral aligned rib fractures. Post-mortem radiograph. Post-mortem anterior-posterior chest radiographs showed diffuse dense bilateral airspace consolidation, classified as complete whiteouts. The arrows show multiple air morphograms. Post-mortem findings. The neck, symmetrical, no trauma. The respiratory system showed combined weight of 2,452 grams, the lungs are firm and edematous diffusely. Edematous right pleura, adhesions were noted, no effusions. The microscopic of this slide showed diffuse alveolar damage in acute stage. The central nervous system, the brain weighed 1,274 grams and there is no gross deformity. The cardiovascular system, the heart weighed 402 grams, no adhesions or effusions or thrombi were noted. There was coronary artery mark of 2 vessels, acute ischemic injury, and abdominal aortic sclerosis. The gastrointestinal tract, no mouth-tongue abnormalities, no esophageal abnormalities were noted. The stomach mucosa was intact. Stomach contained 100 ml of green-brown fluid, increased visceral adipose, no bowel abnormalities, and no appendix were present. Hepatobiliary. The liver weighed 2,232 grams. Noted was hepatic centrilobular stenosis, remote cholecystectomy, right quadrant adhesions, and no pancreatic abnormalities. Genitourinary tract showed arteriosclerosis, oncocytoma of 3 centimeters, benign prostatic hyperplasia, and normal testis. Endocrine showed normal thyroid, grossly normal pituitary gland, grossly normal adrenal glands. Immunological system. There was remote splenectomy, no lymphadenopathy, no thymus tissue was present. Musculoskeletal system. Resuscitation attempt injury was noted. Obesity, osteoarthritis, and knee replacement hardware was found. Molecular and microbiology. Nasopharyngeal swabs were positive for SARS-CoV-2. Lung parenchymal swabs were positive for SARS-CoV-2, and the bacterial panel, respiratory pathogen panel was negative. Autopsy findings showed diffuse alveolar damage and chronic inflammation and edema in the bronchial mucosa. Postmortem laboratory examination. Nasopharyngeal swabs and bilateral lung parenchyma swabs for the SARS-CoV-2 was reported as positive by RT-PCR by the State of Oklahoma Department of Health Laboratory. Nasopharyngeal swab for respiratory pathogen panel, including influenza, was reported as negative. The results were reported in 4 days. This slide shows the different photomicrographs taken from the lungs. In photograph A, you will notice that the airways are patent with no evidence of mucus plugging. The upper arrow points to a patent bronchiole, and the structure is marked by the lower arrow is also a patent bronchiole. Neither airway shows any evidence of mucus plugging, and the pale appearance of the thickened bronchiole is caused by mucosal edema. In slide B, we note that there is diffuse alveolar damage in the acute stage, noted by the arrow that there is already hyaline membrane formation, and in photograph C, we have a chronic inflammation of the mucosa of the airway, which is shown by the arrow. Cells are mostly of the lymphocytic in nature. In slide D, there is interstitial chronic inflammation. This image was taken from one of the few areas where interstitial inflammation was obvious, even at low magnification. In most areas, the inflammation of the infiltrate was sparse or absent. In immunochemistry, in this slide, we see that in slide A, there is diffuse alveolar damage with minimal patchy chronic inflammation. T lymphocytes were highlighted by immunochemical stains for CD8, CD4, and CD3. In slide B, we notice it is positive for CD3, and in slide C, it is positive for CD8. In slide D, we see both CD8 and CD4 T cells, of which the CD8 are mostly highlighted with a few macrophages. There are noted to be more CD8 cells compared to the CD4s in this microgram. COVID-19 studies. Chen Wu et al. Found that markedly lower absolute numbers of T lymphocytes, CD4 T cells, and CD8 T cells in patients with severe cases. The patients with high cytokine levels, lower CD4 T cells, and lower CD8 T cells become more sick and require the intensive care unit, and had a higher likelihood of developing acute respiratory distress syndrome. Severe COVID-19 may be associated with dyspnea, hypoxia, greater than 50% lung involvement on imaging. Critical COVID-19 may be associated with respiratory failure, shock, or multi-organ system dysfunction. Complications may include pneumonia, hypoxemic respiratory failure, acute respiratory distress syndrome, ARDS, sepsis, and septic shock, cardiomyopathy, and arrhythmia, acute kidney injury, and complications of prolonged hospitalization including secondary bacterial infections, thromboembolism, gastrointestinal bleeding, and polyneuropathy. Recently, Wang et al. Studied the cytokine profile of 41 patients with COVID-19. They found that higher plasma levels of pro-inflammatory cytokines in patients in the intensive care unit than in patients who are not. Other findings at autopsy were right pleural adhesions, hypertensive heart disease with microscopic evidence of acute ischemia, coronary arteriosclerosis with marked II vessel disease, arterial-nephrosclerosis, and a right renal mass oncocytoma of 3 centimeters. And sections of the heart showed no evidence of myocarditis. The Oklahoma Clinic death certification, the cause of death was listed as diffuse alveolar damage secondary to COVID-19, and coronary artery disease was listed under other contributing factors. The manner of death that they listed was natural. If we were to do this in the Philippines, our death certification would read as follows. Death certification in the Philippines, as per educational purposes, will be as follows. The immediate cause of death will be acute respiratory distress syndrome with diffuse alveolar damage. The antecedent cause will be interstitial pneumonia. The underlying cause will be COVID-19. Other contributing factors will be coronary artery disease and hypertension. And our manner of death would be undetermined. This is because the etiology or source of the virus has not yet been determined. In engagement of cooperative research, in the biosurveillance research, we look at the pathogen epidemiology by its distribution, its prevalence, and seasonality for COVID-19. COVID-19 has undergone pathogen biology for its genotype, phenotype, and biology to make risk assessments, which informs us of outbreak analysis whether or not this is natural, emerging, and deliberate. So until that time that we be able to find out which the outbreak analysis would be, I probably will classify this as undetermined. Discussion. This autopsy was one of the first to be performed in dissidents who have been tested positive for SARS-CoV-19 in Oklahoma, and their knowledge of this manuscript represents the first published reports of pathologic findings based on complete autopsies in COVID-19 descendants in the English literature. Observations add to the sparse worldwide pathology literature of this entity at that time, and the disease had multiple comorbidities and died of diffuse alveolar damage, which is expected pathological findings in a fatal viral infection. Therefore, this patient likely died of COVID-19. These cases illustrate the challenges that pathologists and the medical community at large will face in determining the cause of death in dissidents who are positive for SARS-CoV-2. Some findings may represent true virus-related pathology, while others may reflect superimposed processes or unrelated illnesses. Separating bona fide virus-related pathology from potential confounders and red herrings in these complex scenarios will benefit from the experience and expertise of forensic pathologists and pulmonary pathologists. Our faculty right now has at least 5 practicing pathologists in infectious pathology. That is a strength that our faculty has at the moment. Okay, to end this, I would like to have a saying. Pathology is the foundation of medical science and practice. Without pathology, the practice of medicine would be reduced to myth and folklore. With this, I thank you for listening and good morning.
To all the faculty here present and the students and guests, good morning. No amount of disaster or crisis can stop us from teaching and learning. This is exemplified today by the earnest desire of the Department of Pathology to achieve this objective. I wish to congratulate the Department of Pathology headed by Dr. Ritualo for having pursued its second virtual CPC activity. It is a job well done and worthy of recognition. To all the students who participated today, my congratulations for having shown your zest for learning and your ability to evaluate a clinical scenario. Thank you everyone and good morning.
And now, before the official announcement of the verdict, which is the most awaited part of the program, we would like to thank each and every one, with the President of the University, Mr. Anthony Tamayo, School Director, Dr. Alfonso H. Loreto, to our Dean, Dr. Enrique Gatmaitan, Dr. Sherlyn L. Ramos, both coordinators for customized program, Board of Judges, faculty members, mentors, and students. This has been a very successful and triumphant activity of the department. Congratulations to all your best efforts, and most especially to the winners. This has been your host, Dr. Miranda and Dr. Haron, once again saying thank you.
Okay, good morning. We now go to the most important part, the ultimate part of this CPC. We now go now to the declaration of winners and how they won. Go to slide 1. I'm showing you right now slide 1, and it shows the table in which we are able to ascertain who will be the winner. The groups are judged on the following: graphics and video content, presentation skill, mastery of this case, the ability to answer questions, and the MCQ. Now you have 4 judges: Dr. Ablasa, Dr. Espiritu, Dr. Palmera, and Dr. Pujal. They have graded each of these groups based on their observations on their video. And each of these judges are supposed to give questions to a specific house. I have color-coded the table into Muggles, Ivelmori black, Voldemort gray, and Doomstrong red. The yellow part are the average of each of their category to answer. So in slide 2, we have the 10 MCQ questions that is counted to 20 points. In this case, Muggles got 7 and they got 14 total. Ivelmori got 7, 14 total. Voldemort got only 5, that's 10, and Doomstrang got 8 out of 20, and that's 16. So Doomstrang got the highest score in the MCQ. Now, if you put everything together, Muggles got their graphics and video content 16.25, Ivelmori 18.25, Voldemort 17.75, and Doomstrang 17.75. It's Ivelmori who won in the graphics and video content. In the presentation skills, Muggles got 17.25, Ivelmori got 17, Voldemort got 17, and Doomstrang got 16. So, Muggles won on the presentation skills. The mastery of the case, in this case, all 3, Ivelmori, Voldemort, Doomstrang got 18 each, and Muggles got 17.5. In the ability to answer from the judges, everybody got a tie. It's all 18. Now, I already gave you the scores for the MCQ questions, and their total, Muggles got 83, Ivelmori got 85.25, Voldemort got 80.75, and Doomstrang got 85.75. In the first CPC, the champion for the first CPC is Ivelmori with 84.33. We add that together, we have the champion for the second CPC, which is Doomstrang at 85.75. They have overtaken Ivelmori with 85.25. We add both the first CPC and the second CPC to get our champion for this year. And our champion for this year is Ibel Mori with 84.79 points. So first semestral champion is Ibel Mori, second semestral champion is Doomstrand, and the overall champion for this year is Ibel Mori. Congratulations to Ibel Mori, the overall CPC champion for November batch, Ibel Mori. We have a grade of 84.79. Thank you for listening to this CPC, and we look forward to seeing you in the next CPC in January of 2021. Thank you.
Finally, we got the winner for the 2020 Clinical Pathological Conference November batch, and their winner is the School of Ibel Mori. And it's headed by Svidyan C.B. Krishna, their leader, and mentored by Dr. Jose Cascosta and Dr. Jean Sobe. Thank you! Thank you! Till we meet next year, expect no patronum!